Thank you so much for watching this video. So today I'm going to talk to you about the resuscitation of a patient with pulmonary embolism. And this is really meant to be a review before the sim session that you're going to attend shortly. So to start off, I want to acknowledge the American College of Cardiologists risk classification when it pertains to pulmonary embolism. So the first category is low risk, and low risk really just means that the patient is stable. There's no signs of RV strain. There's no really severe EKG changes, for example, and they certainly are not hypotensive. The next category is submassive pulmonary embolism. And submassive pulmonary embolism really just refers to a patient that has normal blood pressure, but they're showing signs of RV strain. So RV strain, for example, would be septal wall bowing or RV dilation seen on ultrasound or CT scan, as well as or in addition to troponin elevation on blood work. And finally, massive pulmonary embolism is defined as a patient that is unstable. So unstable would be a systolic pressure of less than 90, for example, and that's actually a specific number that the American College of Cardiologists recommends, as well as cardiac arrest, or if there's evidence of a thrombus in transit. And so these are going to be important to understand, especially when we're talking about thrombolytic therapy and when to use thrombolytic therapy. In order to talk about the resuscitation principles behind trying to resuscitate somebody with a pulmonary embolism, it's important to really understand the physiology behind right ventricular failure and pulmonary hypertension. So what I want to do is actually show you a diagram, and we'll go over this in real time. So let's label this. So this is the right atrium. This is the right ventricle. This is the pulmonary artery. This is the aorta. This is the left atrium, and this is the left ventricle. So in a pulmonary hypertension situation or a pulmonary embolism situation, this is obvious. This big pulmonary embolism is going to cause increased pressure in the pulmonary artery. And as a result of that, that's going to result in increased pressure in the RV, and then RV failure and RV dilation. So RV dilation, I'm going to represent like this. So we'll just say that the RV is now dilated. So dilated that it's actually now coming into the left ventricle a little bit, and that will come into play later. So because the RV is dilated, it's not able to really send as much blood into the left part of the heart. So that then reduces the left ventricular preload. So the preload will, of course, drop. As the preload drops, as we know, preload is definitely important when it comes to cardiac output. As the preload drops, the cardiac output also drops. And as a result of that, the mean arterial pressure drops. So, going back to that right ventricular dilation, as the right ventricle dilates, it also starts pushing into the left ventricle, making that space even smaller, and even less blood can come into that left ventricle, and therefore there's even less preload, dropping the MAP and the cardiac output even more. So when we chat about treatments, I want you to keep this diagram in mind. Moving on to resuscitation. So generally speaking, I think a lot of people will start throwing fluids at people who come into the emergency departments that are hypotensive. It's not necessarily the wrong thing to do in some cases, but in this case, I want you to think twice about it. If you increase the preload to the right ventricle, or increase the volume going into the right ventricle, thinking back on that diagram, that right ventricle is going to start bowing out more into the left ventricle, causing less left ventricular preload, and therefore reduced cardiac output and reduced blood pressure. So the general recommendation would be to start with about 500 cc's to a liter. In addition to that, early vasopressors are going to be key. One of the biggest principles behind vasopressors in pulmonary embolism is to try to not increase the pulmonary vascular resistance, because if that's done, that will increase the afterload on the right ventricle, causing worsened RV failure, worsened RV dilation, therefore worsened left ventricular output. So to start with, norepinephrine is actually a great choice. So norepinephrine is nice because it causes both alpha-1 agonism as well as beta-1 agonism. So the alpha-1 agonism will actually result in vasoconstriction systemically, a little bit in the pulmonary vasculature, but it's more systemic. In addition to that, that beta-1 agonism will result in increased contractility of that left ventricle, allowing for more cardiac output. Norepinephrine is, of course, a great drug, but epinephrine is another option. The only downside to epinephrine is that it does not have as much selectivity when it comes to systemic versus pulmonary constriction. So epinephrine is going to cause more pulmonary vasoconstriction than norepinephrine. And that can actually, as I said before, result in increased afterload to the right ventricle, worsened RV failure, dilation, etc. In addition to those vasopressors that we're all very familiar with, milrinone and dobutamine are also other options. And these are options that are best reserved when norepinephrine and epinephrine have already been provided. So milrinone and dobutamine are wonderful medications in this context because they allow for inotropy specifically of the right ventricle. So that's going to cause, of course, more output from that right ventricle. It also causes pulmonary vascular vasodilation. So that will, of course, relax the pulmonary vasculature, reduce the preload to the RV, and increase cardiac output. The only downside to it is that it can cause very severe systemic vascular vasodilation. And so that can result in systemic hypotension. So if these drugs are used, it's generally recommended to use them in addition to or after you use the norepinephrine or epinephrine first. So we've chatted about the cardiac resuscitation as far as hypotension and trying to increase cardiac output. But of course, because there's so much dead space in a pulmonary embolism, particularly a massive or submassive one, there's a good chance that your patient's going to be quite hypoxic and may need some form of invasive ventilation. The key principle here is to try to avoid positive pressure as much as possible. And the reason, of course, relates to the complicated physiology of right ventricular failure and pulmonary hypertension. This is the right atrium, right ventricle, left atrium, left ventricle. So in positive pressure ventilation, thoracic pressure is increased. And what happens is that venous return decreases. Preload then decreases to the RV, and therefore less output into the pulmonary artery, less filling into the LV, and then less cardiac output, and therefore less MAP or decreased MAP. So trying to avoid positive pressure ventilation in these cases in particular is very important. So be very cautious when placing somebody with a pulmonary embolism on BiPAP or intubating them. Of course, a very good compromise or a very good middle ground would be to place the patient on high flow nasal cannula because there's very little positive pressure in that situation. So using that as a bridge to intubation or to try to even prevent intubation or BiPAP is going to be key. Finally, of course, I want to chat about thrombolytics. And thrombolytics is a very important topic when it comes to treating submassive and massive pulmonary emboli. So I want to break it down in the categories of massive and submassive. So for massive pulmonary embolism, a thrombolytic is definitely recommended. And the thrombolytic of choice is alteplase or TPA. So studies have actually shown that there's a significant mortality benefit with this. So the general dose is going to be 100 milligrams And that's usually going to be given over a couple of hours. So one of the most used regimen would be a 20 milligram IV push over about 1 to 2 minutes, followed by an 80 milligram infusion over 1 to 2 hours. However, of course, things do differ in a cardiac arrest situation. In these situations, the suggestion is to push 50 milligrams of alteplase immediately over 1 to 2 minutes. And if the patient has still not achieved return of spontaneous circulation after 15 minutes, that's 15 minutes, giving another 50 milligrams of alteplase is going to be the next step. When we move on to submassive pulmonary embolism, the general suggestion by a lot of experts is to consider using half-dose thrombolytics. In 2013, there was a trial called the MOPPET trial, or the MOPPETT trial, that used 50 milligrams of TPA in submassive pulmonary emboli. They gave that over a time frame of about 2 hours. And what that showed was that the overall long-term side effects of pulmonary embolism, like right ventricular failure or pulmonary hypertension, were significantly reduced in the group that received the 50 milligrams of TPA. So overall, that's a broad summary of the resuscitation of a patient with pulmonary embolism. A few very important take-home points, I think, would be to define the severity of the pulmonary embolism the next time you see one, understanding the pathophysiology of right ventricular failure and pulmonary hypertension, being very judicious with your fluid, being very particular in your vasopressor choices, as well as considering thrombolytics when appropriate, and finally using positive pressure ventilation only if absolutely necessary. That about wraps it up. Thank you so much for watching this, and I hope to see you soon.